If we could, my name is Maria Williams. She, her, ella are my pronouns. I am the Behavioral Health Metrics and Committee Manager. I'm here to assist with our metrics development. Happy to be here with you all this morning. Just a few things before we get started. Let me see. Pull up the agenda real quick. Hope everybody had a nice weekend. And I welcome you today. Let's see. Sorry, trying to find my notes here. Okay. So welcome everyone. Apologies for the delay. Wanted to just start with some reminders as we begin. So members of the public, we will have an opportunity for you all to provide public testimony near the end of the meeting, probably about the last 10 minutes of our meeting. So we welcome your public testimony, and we just remind you to please send an email to the Behavioral Health Committee mailbox at bhc@oha.oregon.gov, or you can also send a chat message to Kendall Burns, who I would like to introduce at this time. So Kendall is a new member of our team. We welcome Kendall, and I'm going to pass over the mic to her to introduce herself and share a little bit about herself. Good morning, Kendall.
Good morning. Hello, my name is Kendall Burns. I use she, her pronouns, and I am in the Senior Policy Advisor role, supporting this committee, and have just stepped in. Wonderful to meet you all and see familiar faces. Thank you.
Thank you, Kendall. So just for your awareness, we have had a few transitions in our team. So you all may remember Andrea Boichi, who was previously in Kendall's role, is now our Office of Recovery and Resilience Director. So we are excited to have her in that role. And moving on to other opportunities for her. So at this time, I would like to review the community agreements if we have those available. Maritza, would you mind sharing those, please? Thank you so much. All right, so our community agreements. So we invite you to please be curious, open and respectful, seek to learn about others and their perspectives. We ask that we lean into discomfort. It's how we grow. Reminder that every voice is important and that we take space and make space. We take care of ourselves as we need to, walk away, stretch, eat, drink, use the restroom, rest, etc. Confidentiality, we ask that you keep the stories and the lessons we take away and learn from. One mic, one voice at a time. We want to ensure that we're listening with the intent to ensure that we're listening to the individual's experience and what they're sharing with us. Take space and make space. If you are usually quiet, challenge yourself to speak up. And if you share often, please be mindful of leaving room for quieter voices. We would love to avoid jargon as much as possible. Acronyms and industry language. Use inclusive language that is accessible for all. Expect it to get messy and staying flexible. Learning and growing can be uncomfortable, but it is needed. Speak from your own experience. Use I statements rather than generalizations. Challenge assumptions and learn from each other and respect our differences. Be curious of intent versus impact. No matter your intention, you're responsible for your impact. Make room for multiple perspectives at once. We ask that we think beyond binaries. Thank you. And at this time, I would love to welcome all of our committee members to please come off mute and introduce yourselves. If you'd like to raise your emoji hand, you're welcome to do so. Otherwise, please come off mute and please provide some introduction. And if you could please also share, if you were here with us in September 15th, a takeaway from the September 15th meeting. Good morning and welcome, Adam. Please go ahead.
Good morning, folks. Adam Peterson. I use he, him pronouns, and I am with Health Share of Oregon, but here as the representative from the System of Care Advisory Council to this committee. I was not here in September. I was in Vietnam enjoying 2 weeks away from everything related to any of this work, and it was awesome. So happy to have gotten that time, but also glad to be back with you all today. So thanks.
Thank you, Peter, and welcome back.
I can go next.
Thank you, Frida.
Good morning, everyone. Frida Bikele, she, her pronouns. I am a CM and I'm a consumer representative. I was here in September and I do believe there was a long presentation that was shared. We didn't have enough time to really engage. So that's my takeaway from last month. Thank you. Good to see you all.
Thank you, Frida. Welcome. Good morning, Anna. Welcome, please.
Good morning. Sorry I'm late. It's a Zoom update day for me. I'm Anna Day. I use she, her pronouns. I am one of the co-chairs of this committee. And behavioral health, or a child and family behavioral health organization at OCP, is where I'm from. Takeaways from the last meeting, we had a good conversation, or at least good presentation about CCO dynamics and some of the changes with behavioral health directed payments, which is very relevant to the work that we do at Oregon Community Programs in Eugene. So that was very helpful to kind of hear directly some of the upcoming timelines or what's coming next as far as that goes. Thanks all.
Thank you, Anna. Welcome. Good morning, Joe, please.
Good morning, everyone. My name is Jo Johnson. I use she, her, Ona pronouns. I'm in the Oregon Department of Human Services in the Director's Office. I'm their Medicaid Policy and Systems Integration Advisor, and I'm here as a non-voting member representing ODHS. And I think just a takeaway for me is just a reminder that we have a really complex system that's interdependent, and it can be really challenging to navigate, and just so many things are impacting the services of those that our system is meant to serve. So, thank you.
Thank you so much, Joe, and welcome. Good morning, Jorge.
Good morning, everyone. Jorge Ramirez Garcia. I'm a Latino male. I share the sorry for the technical problems. I share the metrics and scoring committee, and I am a liaison to Behavioral Health Committee because of that. And although I love this work, believe me, and I joined this committee when it first started. It was great to have the orientation and have Dave Himbody give us an update on the CCO work and timelines and outlook. The work was really relevant. The presentation was really relevant on the behavioral health aspect of it. But I also appreciate just providing the whole context of the procurement process and opportunities for community engagement. I think that was a great gesture. So I appreciated it and look forward to moving this work forward with you all. Happy Monday.
Thank you, Jorge. Happy Monday. And Andy, are you available to introduce yourself? Good morning and welcome.
Yeah, good morning, everyone. Andy Walsh, she, her pronouns. I'm Senior Health Policy Advisor at the Children's Institute, based in Portland, but I live in Ontario. I serve as the co-chair of the Health Equity Committee, and so I'm on this committee in that capacity. And I unfortunately was not here for the September meeting, but it sounds like it was a good one.
Thank you, Andy, and welcome. Glad you were able to join us today. And I see Sabrina just joined us and I see her logging in, so I'll give her a few minutes to welcome. Welcome, Sabrina. I see you. We just got done with introductions and would you like to introduce yourself, please?
Yes, hi, my name is Sabrina Garcia, and I am a peer department manager in Klamath Falls. I work for a drug and alcohol treatment center called Transformations Southern Oregon, and I also represent Measure 110, now the Burned program.
Great, thank you. Sorry, ooh, technical difficulties this morning are real. Well, welcome everyone. So thank you all so much for being here today and for the updates in terms of what we heard last week and last month, and how that can inform our work moving forward or where there's opportunities for you all to provide some recommendations for CCO procurement in the future. So we will be looking at that for our future planning. Today, what I'd like to just start off with is I shared some documents with you all regarding the crosswalk recommendations, the crosswalk with the CMS, the Center for Medicaid and Medicare core set that we had the activity of last in April, February through April, and then the recommendations were provided to metrics and scoring in June. Today we have Derek Reinke here with us from the Health Policy and Analytics team, and we'll be providing some information regarding just an overview of the Quality Incentive Program, and also, what the role of Metrics and Scoring Committee is. What we'd like to think about today is how you all may be able to provide behavioral health measure recommendations for the 2027 measures to be incentivized for 2027, if that is something that you all would want to do. So for today's presentation, we'd like to hear, just some takeaways or hear about those two that program and the metrics and scoring committee role, and where and how we may be able to, where the behavioral health committee can provide recommendations for 2027 behavioral health measures to be incentivized, if that is something that you all would be interested in moving forward. So with that, I also wanted to ask you all, I know we don't have all of our members here today, but for those of you who are here, if there are any interest in chairing the Behavioral Health Committee, we are looking for folks who are interested in assisting with that chair role. And Anna, I don't know if you would like to just share a little bit about what that role entails, if you don't mind, and maybe that would be helpful for folks. Thank you.
Sure, I can share a little bit. As co-chairs, we get a lot of support from Mireya and her team. There's some conversation after meetings and in between meetings to kind of think about what agenda items would make sense. Kind of unpacking who we should reach out to come and join and provide some presentations, and also thinking a little bit about, especially more recently, on kind of engagement and how to help make the content of these meetings really fit well for the people who are here, and utilizing the wisdom and the experience of those folks who are joining us here. There's a lot of support, so it's not a scary thing.
Thank you, Anna. Well, are there any interest in chairing the Behavioral Health Committee? Sabrina, please.
Yes, I've talked about it before, and if there's nobody else that's interested, I'd be interested. I did do Measure 110 tri-chairs, I think, for 2 years in the beginning. So a lot of hundreds and hundreds of hours at that time were invested into supporting that program. So if there's nobody else, I'd like to nominate myself, if that's okay.
Thank you, Sabrina. Anna, please go ahead.
Yeah, I'm very happy to hear that, Sabrina. I had an inkling that that was a possibility. So I'm very, very thrilled for you to put your hat in the ring for that.
Any objections to accepting Sabrina? I see some hand claps. Yes.
I don't think we have to formally vote for this, do we? We just
No.
kind of by acclamation.
All right. Well, Sabrina, welcome.
Yeah, hearing no objections, we shall move forward. And welcome to the team, Sabrina.
Beautiful. Thank you so much. All right, Sabrina. Well, we will send you all of the invites for you to join us in our journey and endeavor together. Thank you and welcome. We're excited to have you. All right. Well, let me see. With that, I am going to pass it over to our guest speaker, our friend and colleague, Derek Reinke. Welcome, Derek. It's been a while. Please welcome. We're happy to have you here, and we are looking forward to your updates.
It has been a minute. Yeah, thanks for inviting me to come to the committee here. Derek Reinke, I use he, him pronouns. As Maria said, I work with the health analytics team and run a small program called the Quality Incentive Program. I believe Gladys is here and was going to pull up some slides. Perfect. Thank you, Gladys. So we can skip this one. This is just me, who I am. That's my longer title. But basically here today to talk a little bit about the Quality Incentive Program, a little bit of an overview, and as Maria said, especially kind of dive in a little bit more on the timelines that we typically go through each spring as we're considering new metrics and working with our governing committee that selects metrics and benchmarks, the Metrics and Scoring Committee. So in the basic form, the Quality Incentive Program is a way that CCOs can earn some bonus dollars. So CCOs are, again, coordinated care organizations. This is probably a review for a lot of folks. That's the way that we deliver Medicaid services in Oregon. Most are run through a CCO. The Quality Incentive Program is a way to earn some bonus dollars within that. For the last 3 years, CCOs have had an opportunity to earn up to $300 million. And this is on top of the dollars that they already received to cover OHP members' monthly costs of care. Next slide. 300 million is about a 4% bonus. So you might be asking yourself, that's quite a bit. I mean, the overall Medicaid payments in Oregon, the overall flow of money to cover all the needs for Medicaid members is over $7 billion. So yes, this is a lot of dollars. This chart kind of shows the growth in the years. So the program initially started really when CCOs started with the very first 1115 waiver with the federal government. We said that we were going to try to do some things differently in Oregon, including having these regional CCOs rather than just one Medicaid payer. So along with that, we developed this idea that we would carve out some metrics and have some bonus dollars, and CCOs could try to earn those bonus dollars based on performance. Since that time, a couple of years later, that was a bit more codified in some CFRs and some other operating statutes at the federal level, and so there are some other states doing this. CCOs are still somewhat unique in Oregon in terms of being several regional partners, but other states do have some similar ideas in terms of a quality pool and payouts of bonus dollars. You see quite a bit of growth here, even as the percentage stayed the same. So if you look back like at 2016, that was the same percentage, but the overall payout was a whole lot less, just dollars wise. So what's happened there is medical inflation, also a large increase in who was eligible for Medicaid. So think of Obamacare, think of Medicaid expansion. In the pandemic, especially the public health emergency, it really lowered the bar in terms of who was eligible for Medicaid and kind of stopped doing what we call redeterminations, where we kind of go back through month after month to make sure that folks are still eligible for Medicaid, and that was largely paused. So the overall growth was quite a bit. You see that, and there's what I mentioned, the last 3 years of earnings of over 300 million. But one thing that we talked about, and I believe Dave Embody spoke to this a bit last month, was that there's been a definite change in CCO finances. So they are a nonprofit, but in 2002, for example, there was really a pretty healthy operating margin, and that's really kind of evaporated. So in 24, CCOs kind of barely broke even, drawing on reserves. In 25, they were losing a fair amount of money this first half of this year, enough to where there was actually an OHA special payment to try to shore up rates. And as we came to the table with CCOs on the 26 contract, the initial offering that OHA put on the table for a rate increase really was insufficient, and a lot of CCOs said that they weren't going to be able to make that work. They might not sign the contract or operate in the next year. So we had to kind of look for some other dollars in other places. So I think we're going to see a quality incentive pool that is lower over the next couple of years. The LAB proposed there for 25, that is when the legislature gavelled out in June. The legislatively approved budget had dollars for a 3.5% quality incentive pool. But it also only had about 3.5% for a rate increase. And what we ended up having to do with CCOs is give a 10% rate increase. So that, again, that money had to come from somewhere. It's probably going to result in a lower quality incentive pool amount for the next couple of years. Also listed here are the number of measures. You see there was a pretty big decrease right around the pandemic in terms of, maybe this has made too many things to focus on. This last 2026 set that was just voted in, we're at 12 measures, which is the lowest we've been in the program. Next slide. So who sets these measures? My OHA team, we help staff and kind of resource and provide data to these decisions, but it really is a decision-making body, metrics and scoring of 9 public members. So there are 3 CCO seats, 3 seats that are carved out for measurement experts, some kind of research, equity researchers, academic, various other folks in the space. And then there's 3 at-large members, and those can be, really from anywhere. We try in our recruitment to focus on those maybe being an OHP member themselves or working closely with OHP members, working in some kind of a CBO or other kind of community organization to be maybe a bit closer to where some of the benefits are delivered. But in the statute, it's just 3 at-large members for those last 3 seats. Next slide. We do focus on 2 types of metrics. So there's upstream and downstream, and this was a little bit of a change in a Senate bill in 2023 called 966 that changed a little bit of the focus or just kind of clarified some of this. But we have upstream measures. Those are largely homegrown, things that we developed here in Oregon, or maybe they're addressing an Oregon-specific situation. The idea is that they are trying to get ahead of or combat or offset some other social determinants of health, some other kind of inequities in the system. And then the downstream measures are much more classical, clinical related measures, and those come from the CMS core set, as Maria had mentioned. Next slide just has a visual of this idea and kind of where health equity comes in. So in terms of the upstream measure, the focus is there a little bit on trying to disrupt health inequities before they really get a chance to root in, and that we might see some of those effects then in downstream clinical measures and disparities among various groups. And skip this one as well. So then the next slide really, we'll talk here a bit about the selection process. So as I mentioned, the downstream really needs to come from the CMS core set. CMS publishes adult and child core set each year. The bulk of those are required by OHA to report whether we incentivize those or not. So the child core set and the behavioral health adult core set are all required. We're talking about 60-ish measures across all these sets. And the goal in 966 of moving to the CMS core set as kind of the menu or frame from which we could choose was really to try to build in some more alignment and maybe lessen the reporting burden. So there's not, several different versions of maybe diabetes tracking or something like that. There's kind of one that we would be pointing to. 966 also said that we would have 4 upstream measures at a minimum, and it spelled out 4 that we may prioritize. It didn't necessarily dictate which 4, but said we needed to have 4. There are 5 currently on the set. I'll show you the set in later, a couple slides here. In terms of our process of how we're selecting, so we work through with the committee, trying to kind of prepare, pull data together, pull some history together, what's on the core set, what things might be missing, bring to them some data and some various things like that. They go through some selection and review, then things make the set, we do reporting, and then review and revision. In terms of revising, it tends to be a little bit more just of choosing different measures the next time. Although for those upstream measures, those Oregon homegrown, we do have some ability to, change the specs or measure things slightly differently based on issues that might come up. So we typically kick off our process with a pre-selection survey. So we're kind of asking the committee, the metrics and scoring committee, to look for any gaps in the set, anything that they might want to dive in deeper and consider for inclusion. This gives us a chance to see which places where we need to provide them a little bit more data, or maybe a presentation from a subject matter expert or things like that. So the timing on that is kind of in the February-March window. We also can provide breakouts based on demographics, including our more granular real need demographics. And as I mentioned, invite experts and other folks across OHA. Then at the April meeting, has been our process that we provide a full detailed measure selection packet, all of the incurrence incentive measures, anything else they've expressed interest in, all the data on those various measures. We give our recommendations as staff at that meeting, and that's also informed by kind of our discussions across OHA, and we sit with various parts of the agency and get recommendations from public health, for example, from equity and inclusion, in terms of anything where we want to kind of steer the committee or give them some options or encourage them to consider various new measures. Then at the May meeting, they walked away from that with a survey where they're gonna kind of start to select the set. At the May meeting, we go over the results of their survey, and they start to build the set in May and June. That's typically a 2-month window. building about half the set in May, half in June. It sits out as a draft set for public comment and whatnot for 30 days, and then a final vote in July. I just want to note on this screen, so June is when the Behavioral Health Committee was able to make a presentation this last year. There was, advocacy for about 4 measures that you all hoped that the committee would consider. Your highest priority of that group did make that draft set in June, but it was not voted on the final set in July. And that was that 7 and 30-day follow-up for hospitalization for mental health issues. In terms of OHA recommendations, so my team doesn't exactly make that up on our own. We're, as I mentioned, in close contact with folks in public health and various other places. Sometimes the CMS core set has additions and deletions and changes, so we need to bring those to the group. Sometimes measures become ineligible; they're no longer sponsored by a data steward, or CMS has moved away from it. So we try to get recommendations on those various kinds of things. A couple of examples recently. So there was an oral evaluation for folks with diabetes that was an unofficial measure. It was in the program for a long time, but CMS did not pick that up for their menu of adult oral health measures. They did have a couple of other options for the committee to consider. We had Dr. Farag, OHA's dental director, come to the committee a couple different times and talk through options, and he really advocated for one or both measures in front of them, and the committee actually didn't add either of those to the 26 set. Some other things, smoking cessation was kind of an Oregon homegrown, so that became no longer eligible for at least the downstream portion of the set. Public health came and gave some advocacy for trying to redefine that as upstream and keep it in the incentivized set. That ended up not happening. And then I think this group might remember the SBIRT from over the last year. So that's the brief intervention and referral to treatment for SUD issues. That also was a homegrown measure that there was some advocacy to try to keep it around, but it's not a CMS measure, not a core set measure, and was not eligible, at least in the downstream portion. So in terms of the overlap, and this is a recycled slide from my colleague Aaron, but Metrics and Scoring Committee and my team, we're looking at quality incentive measures for CCOs specifically, and have a carved out incentive pool for those measures. The Behavioral Health Committee, was formed with the idea of creating metrics and incentives at a variety of different levels. Didn't have to be CCO specific, could be through those county contracts that I know you've looked at, or other various parts of kind of the delivery of behavioral health care as sponsored by OHA. So obviously there's a little bit of mission overlap there in that, behavioral health metrics for CCOs are a kind of a shared space of interest. And I think there is that opportunity to see what you might all recommend in that space for metrics and scoring. But just a reminder that really per all the statutes and decision-making authority, it is metrics and scoring's ultimate call in terms of what makes that set and what the benchmarks are. Next slide shows the 26 set. So here's, as I mentioned, this is the smallest amount that we've seen in a number of years. Really, this is historically small number of measures. Behavioral health has 2 obvious downstream metrics there. And there's also a behavioral health component to a couple of the upstream measures. So we talked certainly about the social emotional interventions and treatments. that are possible there. That was a homegrown developed metric, and is largely focused on the behavioral health of young kiddos. There is a behavioral health component to the assessments for children in ODHS custody. So that's folks that are kids that are entering the foster care system because of some kind of trauma or family situation, and we want to make sure that we assess all the needs quickly as they come into care, so we can start getting those addressed. And mental health is one of those assessments. Next slide. I've got 2 slides that just show a little bit of kind of where the performance has been. The initiation and engagement of SUD treatment. You see slight improvement. This is a pretty tough measure that CCOs struggle with a bit. I think only about 4 CCOs overall met the marks on both of these. So you kind of have to hit both a rate in both initiation and engagement. So only 4 out of 16 actually hit the improvement mark. It's been a little bit of a slow go. The next measure on the next slide is a screening for depression and follow-up. You see a better growth here, better improvement since the pandemic, that we're really screening and following up. And this is one that was chosen for a challenge pool measure in 26. Challenge pool, just briefly, because CCOs can, performance can vary, and maybe they don't earn all of the dollars in the first pass. The quality incentive program doesn't have the ability to keep any money, so we have to distribute all of the money that's there and collected. So the challenge pool is kind of a way to spend out or distribute any remainders. So there's a first pass. CCOs made so many of these marks. Any kind of unearned dollars become part of a challenge pool, and CCOs then can also kind of make back any other money there, or it can be on top of what they were set to possibly earn. Next slide. So those last 2 slides were brief examples of our reporting. We do have an annual report that's kind of a static PDF version that kind of shows on the overall statewide level how things are going, and then how much CCOs earned. We also have a dashboard that's published a little bit later in the year, where folks can really dive in and slice data and display it by a number of different variables. And as I mentioned, the Real D categories and the granular demographics, we've gotten to the point now where we can report on up to 40 different race and ethnicity groups, language groups, and disability groups. So you can really look for disparities and gaps in terms of CCO service rates or any possible disparities there. And I think that's all I had in terms of an overview, but I can certainly answer any questions or expand in any area that committee members are curious about. Yeah, Anna.
You had said that because of the kind of the funding challenges coming up in the next year, that there was a likelihood that the incentive pool dollars would be less than they have been in the past, although it sounded like it's still kind of TBD exactly how that's going to shake out. But do you have thoughts, or do people have speculation as to how that will affect the emphasis that those metrics have in the upcoming years, or changes that might be in the wider sense?
So yeah, we just had a meeting Friday, and it was kind of a bruising meeting. It was a disappointing meeting, I think, for some folks that have followed the system, because yes, we're talking about a possibility of maybe half the dollars are there, and we heard quite a bit of public comment about look, these are really the dollars that that CCOs are able to float out to providers, to community groups that are doing this work, some of which is non-billable. non-covered Medicaid services takes a lot of money to track and do. And if those dollars are not there, that's not possible. So we came to a spot of 12 measures kind of independently from that funding amount. Maybe it's serendipitous, maybe it was, kind of the trajectory things were going anyway, but there certainly is concern that that it's going to slow some progress. It's going to slow some equity goals. It's going to affect some places like FQHCs, which are already getting hit, with some other cuts from the federal level. We saw a number of the proposed benchmarks, so that they were finalizing benchmarks on Friday. A number of the draft benchmarks get lowered a bit more, kind of based on what appears to be funding concerns. The other thing that's a little bit awkward is we're in a space, per the contract, we're supposed to publish a complete set 90 days before a performance year starts. So that's why the 26 set is now finalized and voted in. But we actually don't know the dollars that will be available in 26. And honestly, we're still getting to a final point in terms of what CCOs are earning for 25, even though we're 11 months through or 10 months through the year. So the ability to kind of adjust number of measures and the benchmarks based on how much money is actually there is somewhat limited. I mean, these should be treated more as true bonus dollars rather than key operational dollars. And with the scope, that makes some sense. I mean, we're talking, the base rates are $7.5 billion, and this program's a $300 million bonus possibility if it's fully funded. But yes, it certainly has been part of the conversations at OHPB, at our meeting last week. Yeah, it's a bit of an uncertain time. I think one thing that's going to mean practically, you already saw this spring that metrics and scoring was pretty reluctant to add anything new, and I think that's going to be my crystal ball is that would continue for at least another year, maybe more. Yeah, Jorge.
I've had the other context again. I share this committee and now have worked for a few years now with Derek and the health analytics team. So I really appreciate this. This is really hard work. Analytics and policy does a outstanding job of keeping this program vibrant in the large portfolio of activity. It has become notably sharper and sharper, and has introduced a lot of important tools that are public friendly and accessible. And I just want that to not go unnoticed about the progress that has been made here. So thank you very much. I do want to share a couple of points of discussion to emphasize that the importance of the program. I think it's fair to say that with the advent of managed care in the space of Oregon Health Plan, it's part of a nationwide trend to have, and also international. I mean, countries that just about any system that has a robust healthcare system has introduced quality performance metrics as a way to start working toward a more prospective way of paying healthcare providers, of tracking the status of what is the healthcare of the population. And I think this is a really great example of how Oregon has taken part of that nationwide trend in terms of participating in quality metrics with the CMS dashboard, but also having the specific program, because there is a dashboard in which we can see measures that are reported to CMS. But on top of that, this program works with an incentive and reward system, right? So that's why we saw all those figures, because it is meant to say, on top of the responsibility in providing services and reporting on quality metrics, we could say we could leave it at that, but no, here's a program in which on top of that, we're going to allocate funds to reward, high improvements, to continue improving each year. So I just wanted to, again, it's a point of discussion. We could, sharpen that about here, but I think that's important to have a systems in which excellent performance and all that hard work is incentivized, instead of having, you reported all these measures and you're not doing so well, how can we, audit you and, put you under scrutiny? Or this is meant to be a positive reward system, and that's part of the value. Obviously, that said, there's very hard operational challenges, such as the lagging data has to clear out for several months after the year. And then, so even if you perform very well in the entire calendar year, you don't see those payments until much deeper into the next year, just because of the data workflows that every state has to contend with. And so I just wanted to remind us of the positive aspects of the program, while acknowledging that we're going into a very hard phase of how do we shrink budgets and do more and more with lower amounts of money. So I have another comment regarding the behavioral health specifically too, but I'll stop with that overview observation.
Sabrina.
Yes, hi. I apologize. Somebody knocked at my door, so I had to step out for 1 second. But I did hear you say some numbers for the initiation engagement of SUD treatment. And I was wondering if you could tell me how many CCOs passed that metric or that standard.
Yeah, that's one that's been kind of a tough one for CCOs. You have to pass. There's rates in both initiation and engagement, and I believe only 4 CCOs passed both of those rates for 24. Yeah. And I go back to Jorge in just 1 minute. I guess I wanted to expand on on one thing. So I talked a little bit through the timeline. As I mentioned, this committee was able to forward some recommendations and come in June to talk to the metrics and scoring a little bit. And while that did make the draft set for consideration, I think we've talked a little bit about how that was kind of a little bit later than ideal. So if you look back on the slide deck, and it'll be sent out, a lot happens before that. I mean, there's kind of a pre-selection survey. There's an actual selection survey. There's a lot of data presented. There's a number of subject matter experts that come to the committee, like the dental director, for example, or some folks from public health. And all of that happens earlier in the spring, late winter. So if this committee is really, wanting to try that again, to really let metrics and scoring kind of know what your priorities in the space are, February, no later than March would be ideal to really have some priorities in place and bring some data and some advocacy to metrics and scoring. That allows my team to make sure we've got all the data and we're presenting all the data to the committee on things that you all see as a priority. It helps us, line up if there's any other speakers that might be relevant for metrics and scoring. And it also would probably benefit this group to, to give those selected metrics, their best chance is also to line up some advocacy. So one thing I heard from the committee this, even though we continue to hold out some space for this committee and presentation, the follow-up of some public testimony to really be in support of a metric might have helped, like in the July meeting when the final vote was there. So the committee, one of my observations is the committee is very much listens to public testimony, folks that come and sign up. So if there's other advocates, in the field, in the system, that could come speak to something, that would probably be helpful. What they heard this last Friday was a lot from folks, with concerns about the shrinking pool and the number of metrics that are on folks, and sure enough, they did lower some benchmarks kind of in relation to that. But anyway, that I think that process is powerful, and I think would have been something that might have helped your highest priority there get a little bit more attention. Jorge, did you have more to add there?
Yes, the behavioral health aspect. This is a tall order with this program because it covers physical health, oral health, and behavioral health in tandem with our CCO model. So you can see about 3 out of 12, about 1/4 of the measures are dedicated to behavioral health. And in this context, that as Derek mentioned, it's going to be hard it's a context of containing and looking for ways to do more with what we have. But to my knowledge, we don't have hard and fast rules about how many measures should be behavioral health within the total. And it is fair to say that behavioral health has gained more and more recognition at the federal level. Those measures became mandatory to report instead of voluntary for states. So there is a lot of traction there in providing more importance to behavioral health. Now within this program, we have that context that was articulated very well right now in terms of the shrinking. So just as a point of discussion also, it is fair to say here that coming in earlier, although the timeline's there and it is, every month, we're gonna decide in June and July, to be as proactive as possible is better. And I think it's also an area of a couple of issues that keep coming up in this context, which are there, but get highlighted in this context, is the issue of administrative burden, and that the organizations have to report a lot of measures. So I think in that context, what is the alignment of the measures in this quality incentive program with other behavioral health measures that organizations are also needing to report? And there may not be a one-to-one correspondence, but I think that there are cases in which there's greater alignment within the context of what this behavioral health committee has as a priority, right? We have very clearly delineated priorities. So looking for that type of alignment, I think it becomes really critical, and I would encourage us to do that. I hope that makes sense. Thanks.
All right. Any other questions for Derek before we move on? Wonderful. Thank you so much, Derek. We really appreciate the update and just the information that'll help us moving forward and deciding what the committee's next steps are, but you provided a great outline of what that can look like. So just appreciate that.
Glad to be here. Yeah, thanks for having me.
Thank you. Okay, well, with that, before we get into our next activity, which we'll be looking at some questions regarding the presentation that you just heard around what was helpful about today's presentation, and is there anything else about the Quality Incentive Program you would like to learn more about? Those are the two questions that we can reflect on. We're going to go ahead and take a 10-minute break. So we'll be back at 11:11, and we will see you shortly. Thank you. Bye. Thumbs up or coming off camera or coming on camera. I see thumbs up. Thank you. All right. Ooh, many thumbs up now. Ooh, that was fabulous. Look at that. It's the little things in life that just make all the difference for me. All right. Well, I am going to share my screen and see if you all. So these are the two questions that we are going to be reviewing or discussing this morning in the second part of our meeting. Can everyone see my screen? Okay, thank you. I couldn't find you all for a minute, so I see you all now. All right, so these are the questions that we have for you. So committee members, you all received an email from me on Friday morning with a link, a survey link to these questions. If you all want to just either, we can do both. We can talk about the questions now that you may have, or comments, I'm sorry, regarding one of the questions, and or also provide feedback. If you think of something later after our meeting, that this link will continue to remain open, probably till our next meeting or so that we can capture the questions that you have in preparation for our future meetings. So starting with the first question, what was helpful about today's presentation? And I'll stop sharing. Sabrina, yes, please.
Yes, for what was helpful to me, even though I heard it before, was when we need to have our suggestions in by next year. So I like the timeline of June, July, but to really understand it would be helpful for our stuff to be in by February is the way that I understood it. And that also public testimony come in to present and for public testimony in July would be helpful. And if I heard those before, I really heard it today.
Thank you, Sabrina. Great points. Any other thoughts around what was helpful about today's presentation?
Mireya,
Yes.
I think it's important to remind ourselves of the context of a important program. So having the not only, you know, this is what happened this year and this is what's going to happen. I think it's important to look at the origin of the program, how it started, and the measures, and you know, the funding allocation, the rationale, the percentages of the percentage of funds that are allocated to the program and how that varies by year. And it's not just, you know, historical knowledge for being a history geek, but you know, there's some practical implications such that, for example, there is a pressure to limit the amount of measures. And when the program started, we're looking about 3,000 measures and upwards, and now we're down to 2,000. So there's already a lot of shrinkage. So as we go into this context of how many measures do we need, well, you know, we're really we're really down to 2,000, you know, range. You know, how much, you know, how many measures can can remain to have a program that's viable. And we're down to 3 behavioral health measures. So that type of information, it's important for us to understand the history of the program and how we can move forward with it, in my opinion. Thanks.
Thank you so much, Jorge. That is another great point as well. Agreed. And I see that Joe put in the chat, I know they mentioned some technical issues earlier. I appreciated learning the process and the timeline that we can plan around to get our feedback heard and integrated into the process. Another great point. Thank you, Joe. Sabrina, please.
Yeah, I have a few things that I would want to know more, like to know more about. And I don't, so can I give those now or should I wait to see if there's any more? Okay, so there's a couple of things. So please just bear with me. One is the number of measures, how those were created. I might have heard that language before, but like I said, I don't remember hearing that and why we have those certain measures. I heard, is it Derek kept referring to something about 966? I wasn't sure what that was linked to, that number 966. And so the other last thing I'd be interested in hearing about in the future, even if it's not around quality incentive and metric, would be the initiation and engagement of SUD treatment.
Thank you, Sabrina. Appreciate that. And 966 was in relation to Senate Bill 966. And I'll just share what Frida put in the chat as well. The presentation was very informative, and the missing link for me is always to understand how this translates into better access for behavioral health services, specifically in rural areas. Thank you. And yes, I will say that, Derek, if there's anything that you want to add or you can answer any questions here, please feel free. Welcome, Matt.
Sure, yeah, no problem. Yeah, so Senate Bill 966 in the 2023 session just did include a handful of changes to how we the frame of metrics that metrics and scoring chooses from, and a handful of things. So that's where it specifically kind of said there's 2 types of metrics, and said that downstream ones all really need to come from the CMS core set. And you need to have some upstream ones, and pointed out a couple possible, it listed 4 options, and 4 of those 5 are what are in there as upstream. So yeah, there were a handful of things that we were trying to do in with that Senate bill. It was initially it was looking to go further. It was trying, the initial legislative concept was to change up some of the voting and seating on metrics and scoring, you know, having some more community seats, having more OHP member voice. There were some more structural changes that were initially proposed, but didn't make it all the way through the legislative process. Excuse me. I think we're still trying to follow some of the intent of that, seeing how more and more we could get OHP member voice, at least as part of these conversations. And as I mentioned, using those 3 at-large seats a little more creatively, and in terms of how we recruit, how we advertise, and really hoping to get more and more of that member experience voice on the committee and in these discussions, because I do think that's something that's missing. And this last Friday was another good example of that, where there was quite a bit of public testimony from the system about, oh my gosh, we're losing money, and then this pool might get cut in half, and then this hasn't even rolled in, the worst of the HR1 federal changes, and oh my gosh, the sky's falling. And what wasn't, I don't think, presented well enough was this is just a bonus program on top of a huge amount of funding, like I mentioned, 7 billion, that pays for the needs of members, and we really need to tap into that member experience and what that's like, and I feel like that's something that's often missing in those conversations. So the idea of that Senate bill was to try to make some more structural changes, but what ended up after it kind of went through the whole process was that really defined the upstream and downstream. We did a study with Portland State that was kind of commissioned by 966, and one of the key things there was really trying to tap into more community experience and community voice, and how to bring that into the process. I would maybe need you to, Sabrina, to repeat the question about how the metrics or how the number, the first part of your question there.
Yeah, I got to turn back to the page really quick. I think it was, how are they created? So we have the number of measures, and I think they fluctuated at some point, but also how are they created?
So the upstream measures are largely now the place for some Oregon homegrown metrics. I think this committee has been presented a couple times with kind of the life cycle of metric development. So something like, let's talk about the social emotional issue focused interventions. So there was a committee that really looked at and OHA and community partners looked at kindergarten readiness, talked about how the system really needs to much more supports and much more services in kind of those youngest ages to get folks ready to be successful. So there was a slice of a preventative dental metric that's really up to age 5. And then the social emotional piece of it is, are there services? Is there an adequate network for young kids that are already, maybe from ACEs scores or from display already of some behavior that could really benefit from some services, even at age 3, 4, 5. And so that was took a number of years to develop that with partners. OPIP is really the driver there. That I'm going to get the acronym wrong. Oregon Pediatric Improvement Partnership out of OHSU, and they're the measure steward. So there's a number of those that are kind of built up in Oregon, and they take a number of years to kind of develop. And the idea was, I think initially of this committee, was that there might be some missing things in behavioral health that could be developed metrics, but acknowledging that takes a couple of years to really dive in with community, see what's needed, and eventually test and then deploy new metrics in the space. The downstream metrics on the CMS core set, that's the selection process of things that are kind of in that traditional clinic space. So there's probably, as I mentioned, like 60-ish on the core sets. We are incentivizing, 7 or 8 of those 60 that we've chosen to put some dollars behind here in Oregon. They're virtually all required to be reported. Our our program just allows, focus on some particular ones. Some of those have been in the program for a long, long time. Some are a little bit newer choices. Largely those are specs then that we can't really control. They're national specs. There might be a data steward like NCQA, Council for Quality Assurance, or some other groups that say exactly what counts or doesn't count in various metrics. And we kind of have to go. It's almost like a copyright issue. We go with the specs that are published per CMS, and if it's on the core set, then we use their flavor of it. If it says blueberry muffins, we can't blueberry muffins. We don't say, well, in Oregon there's Marionberries, which are this slight flavor. If we wanted a metric that was specific about Marionberry muffins, then that would be an Oregon homegrown. But it would be that's a silly example because it would need to kind of be in that upstream space, really social determinants or other kind of structural issues that we're really trying to get ahead of.
Thank you, Derek. And Sabrina put in the chat also, thank you, Derek.
Thanks for putting the ACEs score in there, sir. I do use a lot of acronyms.
Of course, you're welcome. Any other questions, comments, or thoughts? So is there anything else that you would want to learn about the Quality Incentive Program? That was the second question.
I have a comment. And it's important that a part of today is to examine the convergence of the work in metrics and scoring in Senate Bill 966 and the Behavioral Health Committee, which has also its own legislative background and bill. And part of the convergence is health equity. I mean, Senate Bill 966, it clearly states that those adjustments to the Quality Incentive Program, it has as a priority to promote health equity and in a greater alignment of the measures. And Derek mentioned some of the inroads that have been done in a self-assessment, and we've had work groups to work through that. But so that's the bill that established this committee is to for this committee to work in partnership with stakeholders to identify behavioral health metrics that can be useful to this behavioral health system and all stakeholders, and to promote health equity within behavioral health equity. So it's important to keep that in mind, that there's convergence there too.
Thank you, Jorge. Appreciate that. How we involve our interested groups and also encourage OHP members to share their experience with us. Okay. Any other questions? Thank you, Derek. I see your comment also. We do have some from Derek. We do have some OHA analysts who are real knowledgeable about IET, the SUD treatment metric. Aaron and myself could help get a presentation on that if that is of interest, if there's interest in that. I think that would be great. Looks like there would be interest. I'm seeing some hearts. Right. Any other thoughts, comments, or reflections on the presentation that Derek provided today? Is there anything else that you would like to know about the Quality Incentive Program? I'm sorry. Just period. Is there anything else that you would like to know about the quality incentive program? Okay, well, I'm not seeing any other questions or comments. We will, as I mentioned, we will leave the survey open. If you think of things that you want to share later, please feel free to use the survey link to add your comments in there when when you think of them. And like I said, we'll have that open. We'll just keep that open until our next meeting so that we can, this will help us with just gathering information to help with the presentations or information sharing moving forward so that you have what you need and we're providing you the information you need to make decisions moving forward. So one of the things I wanted to just share is if we could, if you all can review the core set again, see if, you want to provide the same recommendations. I would, what I heard also from our partners is that it would be helpful to prioritize those, the recommendations that were made if you want to keep them the same, but maybe having, one or two recommendations that you want to focus on to that can assist with that information gathering and also sharing of what the priority is for you all, what your priority is for measure recommendations. Does that make sense? So hopefully for the next meeting, we will take the information that you all shared today, try to get you some information for our next meeting in preparation for that. And then you all, hopefully by the next meeting, we can decide, you all can think about whether or not you want to make the recommendations for 2027 measure year, and also what are the priorities that you want to focus on so that we have that scope identified. All right. Any questions, comments before we move on to public comment? Appreciate the conversation today and the questions. Thank you for the thumbs up. Appreciate that tremendously. Just wanted to check in as we shift. So it is time for public. Oh, go ahead, Jorge. I'm sorry.
Yeah, no, I'm sorry to interrupt.
No.
Yes, that's a matter of recap a couple of points. It seems to me that the committee's become keenly aware of the timeline that we have, that the earlier the better in the process to have those recommendations, right? And so I would just encourage the chairs and the colleagues who work on this behavioral health committee to incorporate that into the work plan of the behavioral health committee and say, okay, so what do we do if we have this, end goal of by February providing the input, what do we need to do beforehand in the interim to get there? And then to provide that more robust public comment during the voting in June and in July. That became pretty apparent today, I think. And then another thing that I would recommend here for the chairs, and again, those of you who lead this, is that there's important questions and specific measures, right? An example being the initiation and engagement into substance use. So part of that work plan might be, okay, so there are 3 measures there. What are they? More details. What is the performance there? If the default is to keep what's there, let's learn more about them. And then you can request information to have a little bit more of a in-depth on those measures. you already have a lot of hard work on to generate the recommendations of the 4 additional measures. So then you can also, build into the top or 1 or 2 of those 4. Okay, so what do we know about that? And part of that, I'll just underscore, is the alignment. In terms of the mandate of this behavioral health committee, it is inclusive of the quality incentive program, but it's not the only realm in which it can have impact, right? The behavioral health committee, can also be part of other important efforts in behavioral health. So that alignment is going to be really important. Can we draw from other really hard work as the service organizations and are trying to manage more and more measures and administrative requirements with a lower amounts, lower budgets. So then bringing that into the context, I think it's going to be part of an important aspect of the work plan. Those are my 2 cents. Thanks.
Thank you, Jorge. Much appreciated. And so as you all are reviewing that crosswalk, the goal and intent is, to just because the purpose of that was to see, where the goals of the committee, the 5 goals of physical and behavioral healthcare integration, timely access, ensuring individuals are supported in the least restrictive environment, reducing hospitalizations and reducing overdoses. All of those were tied in some way, shape, or form with the metrics that you all were looking at, or the measures, excuse me, that you all were looking at. So that can be an additional piece to elevate the need. And what you were mentioning, Jorge, the legislative requirements. Thank you. Also, just getting all of this. So if we do, you all can come prepared for our November meeting on those decision points, so that we can have discussion in terms of whether you all want to recommend the same measures that you did for 2026, and also prioritizing those measures, again, to tie into the elements where we can do that in that collective discussion when we meet in November of how does this tie into our collective work, and then where are these other bodies of behavioral health work that is happening within the environment that we may be able to make those connections and build our recommendations, community of folks who are supporting these recommendations. All right. Any other final thoughts? Okay, so we will move on to public comment. Kendall, do you have any chats or anyone or any public comment that has come to you? No? Okay, great. Thank you. Perfect. Anyone here? Is there any public comment that anyone wants to make? All right, well, it sounds like we have no public comment, and we are at the end of our agenda. I just want to thank you again. Thank you all for showing up today. Really appreciate our time and our work together. Again, just looking at that homework assignment to review the crosswalk and the letter of recommendations to see if that's something that you all want to move forward, so that we can again start that mapping of the time frame that they're needed to be submitted to metrics and scoring and other, if you want to share it also with the Oregon Health Policy Board to get additional support. That is another area where we can share these recommendations as well. And of course, we'll be sharing with our behavioral health director as well. So any other final questions, comments, or thoughts before we close? Okay, wonderful. I hope you all have a wonderful rest of your day. I look forward to seeing you all in November. I think our meeting in November is on the 17th. Take care of yourselves. I hope you have a wonderful day and rest of the week, and I will see you then. Thank you, everyone.
Bye, everyone.
Hasta luego, Jorge.